So this is a case of a 50-year-old female with a 16 millimeter axial length and a 10.5 white to white. So we're performing cataract surgery here. We are using cohesive viscoelastic to flatten this anterior capsule, which is a little convex. And we will perform a normal controlled capsulorhexis. However, in this anterior capsule, it tends to run out to the periphery. So we're really taking our time here to make it a nice perfect circle, and above all, to make it a good size rhexis. This will be a thick, big lens that we will have to implant inside the bag, and I don't want to struggle to accommodate it inside the bag. So at this point, we will hydrodissect and make sure that nucleus is really mobile inside the bag. We don't want to stretch any zonules that can be weak per se in this eye. Phacoemulsification goes pretty routine. It is a fairly soft cataract. So we're taking care of the nucleus here and making gentle maneuvers, avoiding any anterior chamber collapses or shallowing, and making sure we are injecting enough viscoelastic, since it is a very small anterior segment and we don't want any corneal edema or any endothelial touch that we might have. So it is important to always fill the anterior chamber with BSS or viscoelastic before taking your handpiece out of the eye. And at this point, we will take care of the cortex. Make sure you do it gently because the zonules may not be so healthy. So we will inject viscoelastic once again before taking our IA tip out of the eye. This will prevent uveal effusion or suprachoroidal hemorrhage. And at this point, we will cut the tip of our cartridge just about 1 millimeter. And what this will do is it will create a wider space for the IOL to pass through the cartridge. This is a big lens, so I don't want it to get stuck or break inside the cartridge. This is a +45 lens. So now I'm going to show the lens. Look at this thickness, and I did not edit this part in purpose because I wanted to show you the struggle it can be to accommodate this lens inside the cartridge since it is so thick. So I'm trying to close here the cartridge and it won't click, so something's wrong. I double check and it's popping back out, so I need to push it back inside, make sure I'm not grabbing any parts of the lens and accommodating those haptics inside the cartridge. So this can be a little harder than it would be in a usual lens because of the size, because of the thickness. So I close the cartridge and now it clicks, so we're ready to implant it. I did enlarge my incision because I wanted to deliver the lens right inside the bag, not in the anterior chamber, and in the most controlled way. Now we're flattening that iris with viscoelastic because we will perform an iridosonular hyalodectomy with the anterior cutter. So I'm making a cut in the iris, and through that cut I will go down the zonules and hopefully reach the anterior hyaloid just about 2 millimeters posterior from the iris. And this will create one big compartment inside the eye to hopefully reduce the risk of malignant glaucoma in this patient. So at this point, we're dealing with some iris prolapse. It is very common in these eyes. And we will remove the viscoelastic manually to have it in a more controlled way. I am pushing down the iris to make sure it stays inside the eye while I push down the lens to get that viscoelastic out of the eye. And now dealing with some iris prolapse, and we're done.